All right, well, welcome to tonight's Wu University webinar, Initiate and Expand Dry Eye Protocols in Everyday Practice with Dr. Andrew Fischer. Thank you, everyone, for being here. Thank you so much to our wonderful speaker for being here as well. Next slide. And I'm your host, Dr. Elise Kramer. Thank you so much to Beatrice for exhibiting at this event. So I will introduce our amazing speaker. Dr. Fischer practices at Professional Eye Care Associates in Huntington and Jasper, where he leads the dry eye and specialty contact lens clinic within the practice. Dr. Fischer graduated from the Indiana University School of Optometry in 2018, completed his residency in corneal disease, specialty contact lenses, and dry eye disease at Specialty Eye in Seattle in 2019, and is a fellow of both the Scleral Lens Education Society and the Cornea and Contact Lens section of the American Academy of Optometry. Dr. Fischer lives in Jasper, Indiana, with his wife, Brenna, and their two children, Reese and Rylan. He enjoys spending time with family, hiking, playing volleyball, and barbecuing. Well, thank you so much, Dr. Fischer, for being with us, and I will let you take it away.
Great, thank you. Well, I want to get started saying I don't have any financial disclosures. So I do have a lot of student loans. So if anybody's interested in changing that, just reach out to me. I have my email at the end. But thank you guys for having me tonight to be able to speak about one of my favorite topics in optometry is dry eye. And so today what I would like to talk about is really just initiating the dry eye in your practice. This lecture is geared towards optometrists who don't do a whole lot of dry eye or intimidated by it for several reasons. And just trying to get that into your practice because it's an easy thing to do. We have a whole lot of patients that need our help, but it is kind of a maze to try to navigate. And I hear all the time from friends and colleagues that dry eye is frustrating for several reasons. For one, signs and symptoms don't always match. So do we need to follow the signs of dry eye that we see as in the clinic, or do we need to follow the patient's symptoms? Sometimes we're overwhelmed by too many treatment options and don't know which one to pick or why we pick it. Another frustration I hear is that we feel like nothing works, and it's tough because dry eye, as we'll get into here in a little bit, is a multifactorial condition. So it's not a one size fit all approach. And we'll talk about how we really need to individualize the treatment, primarily identifying the largest or most contributing causes to that patient. But there's almost always something else lying there too that we need to make sure we're focusing on. We'll talk about how dry eye equipment can be incredibly expensive, especially the more in-depth, more advanced treatments that we can do. Now, this lecture, we won't dive into a whole lot of those because I want to try to have you just get your feet wet, get initiated into caring for dry eye, looking at things a little bit closer. So we'll do more broad strokes, just integrating things into your practice. Dry eye is also incredibly time consuming. I have basically half of my week that's dedicated specifically to dry eye and sclerals or custom contact lenses. And the other half is primary care, but half of my week is solely based around specialty eye care. And dry eye is a huge part of that. So I set aside time to spend on dry eye because it is such a common thing and time consuming thing. And we all have this, that dry eye treatment on the patient side is tough because and frustrating because non-compliance is super common, especially as we do our jobs and get the patients feeling better as their symptoms wane. Their compliance to some of the at-home maintenance that we'll have them do also wanes, and we see their eyes get worse and their symptoms get worse, and so that can be frustrating too. But when we talk about dry eye, it's important to know what you're looking for. It's important to know what you're treating. So we need to really figure out what dry eye is. And unfortunately, it is a big blanket cover-all term that can include anything under the sun that contributes to eye discomfort. So we'll look into some of the definitions here. So in 1995, the NEI had a dry eye workshop study that basically defined dry eye as a disorder of the tear film due to tear deficiency or excess evaporation, causing damage to the interpalpebral ocular surface associated with symptoms of discomfort. In 2007, a decade later, the TFOS dry eye workshop study defined some key elements necessary for diagnosis, including symptoms of dry eye, vision disturbance, osmolarity, increased osmolarity of the tears, and inflammation of the ocular surface. They also differentiated dry eye into two primary categories, A being aqueous deficient and B being evaporative dry eye. And then again, another decade later, they dug into it again. Their DEWS-2 study it was a little bit more fluid with some of their definitions here. They did cite that dry eye is a multifactorial cause, meaning there's several contributors to the overall picture of these patients. The disease is a spectrum, meaning it's not, as previously mentioned, it's not just aqueous deficient and it's not just evaporative dry eye, but it's often a mixed mechanism of both evaporative and aqueous deficient dry eye. They also offer a really in-depth approach to treatment protocol. So I encourage you to really, this is easily accessible online, but look at their treatment and management section on this. It's a very, very long study, but it very well outlines a lot of the treatment protocols that I encourage you to get started, at least become familiar with in your practice. They also have a more holistic approach to dry eye in that the report itself says that any indication that specific signs must be present to diagnose dry eye has been removed, and an emphasis is placed on balancing the homeostasis of the tear film, meaning it kind of points to the signs and symptoms don't always match. Some of my patients that are the most miserable dry eye patients have minimal to no ocular signs, and vice versa. I'll have patients whose eyes look like a train wreck and they feel just fine. And it always astounds me that some people that look the way they do don't have any discomfort. So the symptoms aren't as a big factor in the newer study, but I like to boil all of these down into one single definition and make it easier on ourselves. As dry eye is ultimately when the tears and the tear quality do not support the ocular surface health. So getting started integrating dry eye into your practice, the first things we need to do is identify the contributing factors or the bigger contributing factors and target those. It's important to keep in mind throughout this whole process that very, very thorough patient education is incredibly important, especially in those patients that we see signs in the microscope, see signs clinically, but they don't feel anything. I like to really utilize imaging, anterior segment imaging, myopography, if at all possible, because a picture is worth 1,000 words. If those patients see what I'm seeing and they realize, wow, that does look bad, or we'll compare that to what a normal or healthy eye looks like, they also can buy into that because they see the damage that's being caused on their eye. And then it's important as well to keep in mind as you're treating and identifying all these problems that every single dry eye patient is different. And so something that works for patient A may not work at all for patient B. So you do have to modify as you go along with the treatment. But for today, we're going to kind of get, again, broad strokes, identifying the most common factors and things that we can do in our office. So to get the conversation started, it's important that we ask the right questions. In symptomatic patients especially, a thorough patient history is going to tell me as much about the treatment plan that I'll have, at least at that initial visit, as much, if not more, than what I see behind the microscope. On the asymptomatic patients, we do have to rely on our clinical signs that we see, but it's really important to take a thorough patient history, or at least review your technician's patient history with that patient, and it gives you a whole lot of information there as well. So I like to utilize questionnaires in my practice. There's a bunch of different questionnaires that we can use. Several of them are listed here, but I was trying to find a questionnaire that works for us. I wanted something that was incredibly easy to understand for the patient, so our techs didn't have to take 5 minutes to explain what they were doing. I wanted to be very quick for the patient to fill out, very quick for the technician or myself to grade, and something that's repeatable as well. So the one that I use in my practice is a speed questionnaire, or it's a modified from the standard speed questionnaire. I was graciously shared this with Dr. Damon Durker at the Eye Surgeons of Indiana during one of my rotations through optometry school. And I found that it is very easy. It might take 2 or 3 minutes most for the patient to fill out. You can grade this in about 30 seconds if you're good at mental math. But in short, on this questionnaire, we've got plenty of symptoms relating to dry eye at the top portion. So I just have the patient circle them, including none. So if the patient's asymptomatic, great. They fill out that top section, they're pretty much done. This speed questionnaire is scored from 0 to 28, 0 being no symptoms, 28 being severe dry eye. And everybody has their own cutoff on when they really dig into the dry eye more in depth for these patients. So for me, when I see a speed score of 8, that kind of raises my red flag of, maybe we need to bring you back in, talk a little bit more, investigate this as well. So 8 is kind of my cutoff. I've seen some clinicians as low as 5 or 6, and some stretch it up to 12 or 13 to wait for the more severe. But in my opinion, if we identify dry eye early, we catch it early, it's one of those diseases that if we identify and stop the progressive damage to the eye, we can have a lot better outcomes rather than wait for it to be too late. This specific questionnaire, I believe, was made by Dr. Corbin, Dr. Blackie, and it does correlate a little bit higher with meibomian gland dysfunction compared to some of the other questionnaires. But again, I like it because it's short, it's easy to understand, and at least gives us a good starting point on this. How I utilize this in my practice is I have one in every room. It's laminated, and I have the patients use a dry erase marker. That way I don't go through a stack of paper every single day, but pretty much every exam, I try to give this. I have my technicians, after they're done working the patient up for me, I give that to the patient, receives this and fills it out while they're waiting for me to come into the room. And so I usually come in, grade it, and if it's high, we'll talk about dry eye, and I'll do a little bit more thorough screening on them. If it's low, I'll still do my normal dry eye screening I do as part of the exam, but it just helps start that conversation and have dry eye be at the forefront of their mind if they're having issues as well. Step 2, after we identify some of the symptoms that that patient might have, then we really dig into how do we identify the types of dry eye that that patient is exhibiting. And so this is another big hurdle for treating and managing dry eye. And again, it's something that a lot of doctors don't want to integrate in because of the expense. But I'm very, very much of the mind that there's not a whole lot that we truly need to get our feet wet and start evaluating for dry eye. Truthfully, I think there's 2 things that are vital, and the rest we can add as we go. But the 2 most vital things, in my opinion, that we need to use for dry eye evaluation, number 1 is a way to accurately and repeatably assess the meibomian gland function, as well as the quality of the expressed meibum. And so this can be as simple as using your finger, using a Q-tip. There is a tool that's called a meibomian gland evaluator that you see there on the top right that I tend to use most commonly because it is a repeatable pressure that you put on the eye. I'll get more into that in just a little bit. The other tool that I like to use in my arsenal, as far as the bare minimum that we need, most of us probably already have in our clinics, and it's a lissamine green strip. And this is a way for us to see and evaluate when the tears don't support the ocular surface health. Expanding that just a little bit further, again, with tools that we already probably have in our clinic, sodium fluorescein strips, a Ratten filter to really make that corneal staining pop for us a little bit, as well as a transilluminator. I'm spoiled because most of my slit lamps in my dry eye clinic have a built-in Ratten filter, so I can tell you I almost never look at a cornea anymore for dry eye staining with fluorescein without using my Ratten filter because it's there and it's easily accessible. You can purchase these big rings that you can find here too, but almost every conference that I've been to, especially with some of the contact lens related conferences or some of the stands there, they have little cardboard ones with Ratten filters built in that you can snag next time you're at a conference, and they really, really help make that fluorescein staining pop, especially if the corneal stain is very, very subtle or very, very fine. I also find that using the fluorescein as well as the Ratten filter helps bring out ABMD. Even the most mild forms makes it a whole lot easier to visualize as well. And then some things that I really like to have, but I don't think are necessary. I really like when I'm looking for dry eye, some sort of inflammation testing. So without having a huge expense in integrating this in. There are inflammation specific tests that you can get into the office. There's some paperwork involved because you need to have clear waivers to be able to perform the specific inflammation test in your office. But it's not a huge expense. It's not a huge expense to the patient either to test that. And I really think confirming whether there's inflammation present on the eye or not is important. I also, like I mentioned earlier, like to use interior segment cameras. And if you don't have one already, if you have an old iPhone or smartphone laying around, you can get an adapter for a slit lamp for $20 or $30. And again, I think pictures speak 1,000 words, because if you can show that patient what you're seeing on their eye, it really helps them also buy in, especially in those asymptomatic patients. I also like to have a way to visually image the meibomian glands using a meibographer. There are apps that you can get if you have a phone that has infrared setting. You can also use your phone in some cases to be able to image the meibomian glands. In my other office, not in my dry eye clinic, I don't have a true meibographer, but I have an anterior seg camera that does have infrared. So I am able to take a meibography at those appointments too, really just to look at what the gland structure itself looks like. So as a whole, these tools here, most of which that most of us will already have in our practice readily available, are truly the only things that you need to do a thorough dry eye evaluation and start integrating this into your practice. So now that you have the tools of the trade, now it's time to figure out what we're looking at. And so again, this dry eye is a multifactorial condition. And so there's many, many factors. And so what I tend to do on my evaluations is I try to identify the ones that are contributing the most or making the patient the most uncomfortable. And so the first thing I generally screen for is meibomian gland dysfunction. And as the name says, meibomian gland dysfunction is when the oil glands and meibomian glands are not functioning. A study by Limp et al. In 2012 showed that meibomian gland dysfunction is the most common form of dry eye. In 86% of dry eye patients had MGD, with 50% of those patients having just meibomian gland dysfunction and 36% having mixed meibomian gland dysfunction as well as aqueous deficient dry eye. But you can't look at the eyelids themselves oftentimes and say this patient has meibomian gland dysfunction. Again, another study by doctors Blackie and Korb showed that non-obvious meibomian gland dysfunction is incredibly common, which means there's no signs of inflammation. There's no signs that those glands work. So you physically have to push on that eyelid and check the function of those glands to determine if they have meibomian gland dysfunction. And I'm a big believer in that these two gentlemen are a big driver of meibomian gland dysfunction and why dry eye is becoming more and more common, because we are on screens all day long, every day long. In fact, I looked it up this afternoon. The average daily screen time of an average American is over 7 hours per day. Looking at our phone, looking at our computer, looking at digital devices, and all this near work does decrease the blink rate. So when I was going through school, we were always told that screen time or working on a computer can decrease the blink rate by up to 60%. A couple more recent studies on that showed that it was probably closer to 20%, but there was a much higher incidence of incomplete blinks. And so the reason that's important, the incomplete blinks or the decreased blink rate while we're doing screen time or doing near work or tasks that we have to really concentrate and focus on, comes down to the anatomy of the eyelids. And specifically on those oil glands, the oils in the glands move towards the eyelid margin and are expressed through the meibomian gland orifice, going through the duct. But that tear duct, or the duct where the oils come through, is encirculated by Rieland's muscle, which is in open eye environments constricts or closes off that tear duct. And so that's why when we're looking at our patients under the microscope, they're not constantly oozing or expressing their meibum. That muscle of Rieland is opened or relaxed when the eyelids have pressure on them, specifically during a blink. As the eyelid blinks, that muscle relaxes, the oil gets excreted and pulled onto the ocular surface, or when we're in our slit lamp and giving that eyelid some pressure, that can express those oils because we are expressing them out by relaxing that muscle and giving some pressure on that gland. So without a full and complete blink, without those eyelids physically touching, the oils don't come out. And when we're on screens, they, if our blink rates decrease or we're not a great full blinker, those oils over time go from being a liquid or olive oil consisting like they should be to a little bit thicker and inspissated to a little bit thicker and gel-like to the toothpaste or Cheese Whiz videos that we see online all the time. And eventually they'll get so thick that they turn into a waxy cap and block themselves off. And at that point, we need more intense treatment to get those glands cleared out. And so evaluating for meibomian gland dysfunction, if I go back to one of my favorite tools that I use in clinic is a specific meibomian gland evaluator. This meibomian gland evaluator has a spring inside of it that when it's depressed, not fully compressed, but when we're just using the tension of that spring, it exerts a pressure of approximately 1.25 grams per millimeter squared on the eyelid, which happens to be about the force of a conscious blink. And so using this tool, I can repeatedly and reliably get the number of glands that are functioning. So I know when I use my finger to look at the quality of the oils, I tend to squeeze and squeeze and squeeze until something comes out. Where on this, if I'm not fully digging into their eyelid, I can repeatedly apply that same pressure consistently. And so I know my evaluation is consistent exam after exam after exam. And so I can really hone into if we are improving this patient's oil gland function. There's several ways to grade these. The most accurate way, I think, in my opinion, would be to find the meibomian gland secretion score, which is simply dividing the eyelid into 3 sections, each nasal, central, and temporal, each approximately 5 glands or so, and seeing how many of the glands express oil out. And then you can multiply that by the quality of the oils. So for instance, on the nasal section, if a patient has 5 glands, but they're all thick or gel-like, their total score would be 5 glands times a 1 as far as the quality, giving you a score of 5 in that section. A perfect eyelid is about 45, so you have all 15 glands functioning at a grade 3. I simplify it a little bit. I think if I had a technician, or a scribe, it would be a little bit easier to remember all these numbers and then document at the end. But I tend to just grade the glands that are grade 2 or 3 as far as their quality, and then total number of glands per section. So for instance, on my documentation on a bottom right lid, I might have 3, 3, 3, which would mean there's 3 glands on the nasal section and central and temporal that are all either grade 2 or grade 3 quality, because those are the quality scores that I'm really looking for that express out and coat the eye with the meibum. As far as total number of glands, meibomian gland dysfunction is 6 glands or below. We do need approximately 6 functioning oil glands with thin oils coming out of them on the eyelid to maintain the homeostasis, the proper lipid layer on the anterior surface of the eye. 6 to 10 is kind of in this borderline gray area that patients generally do pretty well here, but I'd really like to see a patient that has 10 or more functioning glands with gland quality scores of 2 or 3. So if a patient, when I'm doing my meibomian gland evaluation, if they have 6 glands per eyelid, I typically will discuss we need to do some intervention. And even on those borderline scores on especially a symptomatic patient, we need to try to make those glands better, not only for their symptoms now, but again, preventing progressive changes on those glands and getting them to function better. So this is where the transilluminator comes in. You don't need a specific meibographer to try to evaluate what the oil glands themselves look like, the oil gland structure. Oftentimes you can just divert their lid in the slit lamp and look at them, the inner side of the eyelid, and you can see the glands, but it is harder on patients if they're not really thick or inspissated glands or swollen glands. It's hard to evaluate that sometimes. So what I do is I take my transilluminator, I invert the eyelid with that. I kind of have my slit lamps beam off, but I get the eyelid in focus in the oculars, and using retroillumination, you can see here in this photo, you can see the meibomian gland bodies there. And the way I grade the meibomian gland, or the meibography, or their meibomian scores as far as their gland structure or gland health, is really the total area of atrophy. So for instance, this patient, approximately 50% of their total inner eyelid has atrophied away. And so they're between a high grade 2 or a low grade 3 as far as their total meibomian loss score here. And so once you identify that meibomian gland dysfunction is there, there's two first line treatments that I will recommend. And honestly, I think most people that have eyes should be using these on a consistent basis anyways, but a heat compress and high quality omega-3 supplements. So our goal with the heat, especially in those patients that do have thicker glands, is we're trying to melt down those oils. We're trying to make those oils go from a thick gel or solid into a thinner, more liquid oil, so they express and spread across the surface of the eye a whole lot easier. In my office, we utilize two different forms, one that's an electric one that is a microwavable one. I tend to lean towards the electric ones as much as I can because this part, the patient compliance is tough. It doesn't sound like 10 minutes a couple of times a day would be a challenging thing, but it is hard for a lot of patients to find that time to do. And so I like the electric ones. And I tell patients, I'm a snooze button hitter in the morning. I roll over, hit snooze 2 or 3 times, but during one of those times, I'll roll over, grab my electric mask and put it on. And so I'll take an extra 10 to 15 minutes in the morning with my heat, and I start my day out that way. They can also do it at bedtime. They can do it over lunch. So I always make sure I emphasize time of the day is not important. It's getting that heat on. The microwavable ones are a little bit more nuanced because they have to get pretty darn hot to be effective because they do dissipate that heat, where the electric ones stay at therapeutic levels for the entire duration that mask is on. So I always tell patients, if they go with the microwavable mask, the first minute or two should be hot but not comfortable. It shouldn't be painful. I don't want them to come back with blisters around their eyes, but the first minute or two should be not relaxing because we need that heat to be at therapeutic levels for at least that 8 to 10 minutes and attempts to soften those up. There's also a little bit more inconvenience with that. And I know when I switched to the electric one, it was because I was very non-compliant with my microwavable one, because it was everything I took when I laid down in bed and I saw my mask on the nightstand to get up, walk across the house to the kitchen, and then go lay back down again with it when I tried to do that in the evening. So for me, I just tend to lean towards the electric one more. The high quality omega-3, there's always 2 criteria that I really look for when I'm prescribing omega-3s. Is number one, that omega needs to be in a triglyceride formula. And we'll get into this here in a little bit. But the triglyceride-based formulas, we have a whole lot better bioavailability, so they work a lot better. There's 2 main ways that omegas commonly are made. One is with this superior triglyceride formula, and the other is an ester-based formula. And it's just harder for our bodies to break down and process the ester-based ones, and so we just get a lot better benefit with the triglyceride ones. And the dosage that I always will recommend is at minimum 2,000 milligrams per day when the EPA and the DHA are combined. But short of that, there's several fantastic options out there that meet those 2 criteria, but making sure you lay out exactly which ones or what they need to look for on the label is vitally important here. As far as the heat masks go, there are some limitations to that. And like I said, a lot of it is just complying and doing the mask on a regular basis. But you can see on this left side here, there is a big difference in temperature between what we hit on the outer surface of the lid or right under that mask versus the heat that's transferred all the way through the several layers of tissue. And the eyelid's not a super thick tissue, but you can see in the study, we lose about 9 degrees worth of heat by the time that heat gets to the inner lid. And so we need to maintain that heat for a long period of time, that 10 minutes of time, to have any effect on thinning those oils. And the difficult part with this is the outer eyelid temperature that's bordering on the pain threshold for most patients, as far as the heat that people can tolerate. The other limitation to external heat is for those glands that are so thick and so waxy, they're recalcitrant, that sometimes we don't expect to see a big swing in gland function with these, because those glands are so thick that the heat that we get to them externally is just not enough. but I still think it's an important part to have in our protocol because the hot compresses really do a good job of those glands that are already functioning. It keeps them functioning. The glands that are thicker, gel-like, or inspissated, it can show over time if they're continuing to use that on a regular basis, it can show that those glands can thin out. But those really thick, solid glands, I tell the patients if they have their whole eyelid that way, I don't expect to see a huge swing in those. I've been surprised before, but for the most part, those thick, waxy glands aren't going to show a whole lot of function with just the heat compress. Um, as I mentioned earlier, the triglyceride formula in the omega-3 supplement is vitally important. Our absorption rate is a whole lot higher in a triglyceride form versus the ester-based form as far as our bioavailability. And generally, there's a whole lot less fishy, burpy side effects. Natural triglyceride form, if you're eating salmon, they are easier to digest and for our bodies to process. This study on the right here is a meta-analysis of, I believe, 17 different studies on using omega-3s in your dry eye protocol. And as a whole, the study found that most of the studies that were in this meta-analysis increased the clarity of the meibomian gland secretions, decreased the lacrimal gland apoptosis, we increased tear breakup time, we increased Schirmer scores, we decreased symptom scores, and omegas have a great anti-inflammatory benefit, which is why most people take them in general for joint health and heart health and brain health. But again, this is something I think most everybody should do just for overall health, but specifically when we're finding that they have signs and symptoms of dry eye, specifically MGD. I won't go too far into detail with these two articles, but they're really good as far as outlining as a whole what omega-3s can do for you, not only for dry eye. So the article on the left here by Dr. Somerton does outline several other health benefits that omega-3s can have outside of just dry eye. In 2018, there was a study called the DREAM study that compared omega-3 supplements to a placebo, which is instead of an omega-3, it was olive oil. And that brought up some questions on are omega-3s truly beneficial? But in this article here by Dr. Rojas, basically everything that we found, he cited that meta-analysis earlier too, is that we still think at this point that omega-3s are very important to have in our dry eye protocol. But after the first line treatment with the heat and the omegas, as I mentioned earlier, sometimes that's just not enough. And so this is where investing a little bit more into your practice or getting some more things that you can improve that function of the oil glands. And so I'm a big Indiana Hoosier fan. Our former IU football coach, Tom Allen, had a saying, LEO, which he said stands for love each other. I think he was talking about meibomian gland dysfunction and that the way we treat this past that first line is that we need to liquefy, express, and observe. So that's what LEO stands for, in my opinion here. But we liquefy the oil glands going from a thick meibum to a thinner. We express the oil glands out, and then we observe for improvement after we do that. And these more expanded approaches, these more advanced approaches that we can integrate, there's several of them out there, but they all initially, they all involve heating the eyelids and the oil glands and then manually expressing those thick oils out. But again, this is definitely more of an advanced thing that would be an investment into your practice. But if it's not something you're willing to do, but you identify this patient has needs that they need to get those glands functioning, I always encourage people, and I know it's hard as in optometry as a whole, that we don't like to refer people out. But if your patient has a problem and you're not able to fix it, let's all try to get what's best for our patient and get them to someone who has these to take care of that. And I think building that relationship with some of your other ODs around not only can help gain trust in your patients on your end, but also can help gain trust on those practices that do have these more advanced therapies here too. So outside of that, the hot topic in MGD and dry eye in general right now is intense pulse light and radio frequency. And specifically for MGD, what this does is it can help liquefy a little bit. It can help liquefy the viscous meibum. It dilates the glands. It helps with inflammation from rosacea that congests the glands. Radio frequency is a heating procedure, and then most of the time this is followed by expression. Usually comes in a combination of 4 treatments, at least initially, and most of the time the manual expression is done after the second or third or fourth treatment can be done on every single one as well. And then another one that's out there too is low level light therapy. I would say this one's not as common or not as widely used as some of the others that we just went over, but low level light therapy is a form of photobiomodulation, and through the application of LEDs in specific wavelengths, those wavelengths can penetrate the skin, promote healing, promote collagen repair, and get those glands functioning a little bit better as well. And oftentimes this is also used in combination with one of the other therapies as well. Oftentimes there's heating and expression followed by this low level light therapy to help promote healing. So now that we've addressed the meibomian gland dysfunction, I jump into the vital dye staining. As I said, I think lissamine green is one of the biggest things that we can use here to detect dry eye on these patients. I look for bulbar conjunctival staining, lid wiper epitheliopathy, line of marks, and really severe corneal staining can absorb some of that dye too. It's more commonly, we all use fluorescein staining for corneal staining, but partial blinking analysis, and basically that's just after the fluorescein is in the eye, I'll evaluate the patient's blink, and you can kind of tell where the fluorescein covers their eye and doesn't after they blink. You can also see lid wiper epitheliopathy and bulbar staining here. I typically prefer, especially with the fluorescein, to try to not use anesthetic on them. It is more viscous. It does not give us as accurate results for tear breakup time. And it also anesthetizes the cornea to a point where their blink rate typically is a little bit more decreased as well, because they don't have the sensation of their cornea after you put those drops in. For corneal staining, for conjunctival staining, oftentimes, unless you're doing lissamine green, you can't see this. Unless it's pretty severe, sodium fluorescein does not make this pop. The Ratten filter can help with that, but you really need to use lissamine green staining to evaluate the conjunctival staining. Oftentimes I'll see the conjunctival cells stain before the cornea. It's often a little bit earlier in the process. Most of the time I see nasal staining before the temporal aspect when we're using vital dyes here with the lissamine green. And the cause for the staining is often rapid tear destabilization due to exposure, due to lack of lubrication, due to disruption of the goblet cells. And this disruption of the goblet cells can lead to decrease or increase symptoms. The way I grade this, the most specific way, again, if I had a scribe, I would rattle off each zone of the conjunctiva, like this photo shows here. I basically just grade the right eye nasal, left eye nasal, with how much staining that they have, and then also we'll document the temporal aspects of that too. One thing I see often as well when I do these, especially on regular exams after I do my contact lens evaluation, I'll throw in some stain, and you often see this ring, this circumlimbal conjunctival stain with that ring, which is super common. It's typically not associated with any contact lens dryness or discomfort per se. It's usually the result of a tighter fitting lens, and that lens fitting tight just grabs and digs into the conjunctiva, disrupting the goblet cells, causing some mechanical trauma. And so I had a patient that came in just for a second opinion because he had some redness. He didn't really have discomfort, but his eyes always turned red after he was in his contacts. He was in a good lens, highly breathable lens, but I noticed on the eye it didn't move. So I had him take it out and stained him, and he had this clear ring. He had been on steroids before. He'd been on lifidographs before to try to improve the comfort or improve the redness that he had. Nothing helped. I switched him out to a little bit looser fitting lens, saw him back a month later, didn't have any issues on the cornea, no redness, no discomfort. So sometimes it's just a matter of seeing that ring, trying a looser fitting lens to see if that will help that. As far as contact lens related staining goes too, we're all quite aware of the 3 and 9 staining that we see specifically in gas perm lenses. A lot of the times that can be secondary to partial blink, which is again common in gas perm lenses because of the constant feeling of that gas perm on the eye. It could be due to a low lid position, excessive edge lift on those lenses, as well as just thick lens on the gas perm there. That's hard to overcome though, especially in long-term gas perm wearers. So when I see this, I really make sure that we're beefing up the lubrication on them, changing the lens fit as needed. Um, Something I use as a quick screening tool when I do listamine green, when I'm looking at the eyelids, is called the line of marks. This doesn't really dictate anything on my treatment, but it's a quick screener that we can use. This line of marks is where the conjunctiva, the palpebral tarsal conjunctiva, transitions into the epidermis. And so there's this keratinized layer that should be, as this picture shows, on the inner side of those oil glands. But over time, as dry eye progresses, that line of marks can protrude past or at the meibomian gland orifice. And that's a good screening tool, really quick screening tool that correlates pretty highly with age, with meibography scores or meibomian gland secretion scores. It doesn't truly tell us the function of those glands. So when you're evaluating here, this is still having to express their glands to look at the quality of those oils, but it can be a really quick screening tool to use. I also like to look at this, that if they have a whole lot of keratin buildup on their eyelids that could be blocking those meibomian gland orifices, something that eyelid exfoliation could be very, very beneficial for here too. A very common thing that I'll often find here is the lid wiper epitheliopathy. So the lid wiper is again, right near that transition zone, but it's the part of the eyelid that actually rests on the eye and spreads the tears across the eye, pushes and pulls the lipid layer. And so without proper lubrication, I make the analogy to my patients when I'm doing my education is that when I see this staining, it's similar to having a windshield wiper with no rain. You turn on the wiper blades and that wiper rubs and rubs and rubs on the windshield, and on the eye without proper lubrication, that eyelid rubs and rubs and rubs on the cornea. And as it does, because of improper lubrication, that rubbing on the cornea can cause micro trauma that over time can lead to inflammation, which over time kind of gets us into this vicious circle of dry eye, inflammatory dry eye. And so when I see lid wiper epitheliopathy, it's kind of this red flag to me of saying, hey, we got to make sure we're keeping an eye on this. Lid wiper epitheliopathy is incredibly common in dry eye patients. Several studies I'll cite here quickly. In contact lens wearers, 80% of patients that are in contact lens that were symptomatic for dryness had lid wiper epitheliopathy. A later study of patients that had lid wiper epitheliopathy without any other specific dry eye signs like conjunctival staining or corneal staining, almost up to a quarter, 3/4 of those patients were symptomatic for dryness without having any other signs. So again, this tells us without using the listamine green, it's hard to pick this up. The study of patients with lid wiper epitheliopathy with dry eye, 88% of patients with other dry eye findings also had lid wiper epitheliopathy. So again, it's something that's important to keep an eye out for with how highly correlated it is with dry eye, or especially early dry eye. And so to grade this one, put your listamine green stain in, you basically look at the total area of that lid wiper that is stained. You can grade it in horizontal length of staining. So on the bottom right, you see that entire eyelid from temporal to nasal has a bunch of listamine green on it. That's the entire length of that lid. And you can look at the height of that staining too, meaning if half of the lid wiper is staining with green, that's a grade 1 to 2. If it's the entire thing, like again in that bottom right picture, they're grade 3. So just something to document, because if we improve the lubrication on the front part of the eye, listamine green also can improve. And again, it's something we can get out ahead of a lot of their symptoms. But when we're talking about corneal staining using the listamine green, the location tells a lot of the story here too, and the type of staining. So on these patients that have inferior staining, the first thought that comes to my mind is that it's due to exposure, partial blink, or nocturnal log ophthalmos. They're just not coating that bottom third of their eye with tears. Nasal staining I often find is correlated with goblet cell dysfunction. Oftentimes inflammation is present when there's really dense nasal corneal staining. And these patients too, if you're also utilizing listamine green and corneal staining, they'll often have a lot of listamine green staining on the nasal conjunctiva. Temporal, I find, typically correlates with eye rubbing. Patients tend to rub on the outside here and get a little bit more mechanical disruption of those cells on the cornea. And then superior staining, both lissamine green and corneal staining, I think something under the eyelid or systemic involvement, specifically on contact lens wearers. I always make sure that they don't have significant papilla or GPC here. But systemic things to keep an eye out for is thyroid, rheumatoid arthritis, Sjogren's syndrome as well. For staining, first line therapy, increase lubrication, get their oil glands better. If it's severe enough, if they have diffuse staining across their cornea, really thick recalcitrant staining on their cornea, oftentimes you'll have to pull out an anti-inflammatory eye drop to do that, to pull out some steroids. And then we need to restore goblet cell density to take care of the overall health of the front part of the eye. As far as what treatments to use on them, first line, I tend to lean toward lipid-based artificial tears, primarily, again, because my meibomian gland dysfunction is such a big factor. These lipid-based tears tend to stay on the eye and coat the eye a little bit better than the water-based tears. But ultimately, I tell patients artificial tears are a Band-Aid. They don't fix the problem. They help with symptoms. So if you find one you like better than the other, as long as it is preservative-free, that's the ones I go for. I tend to avoid the preserved eye drops, just because some people, they are more sensitive to those, and that can throw in another factor that can cause more irritation. So for most people, preservative-free, lipid-based artificial tears are my go-to, but any other preservative-free ones are, in my opinion, are more than fine to help with their symptoms. Past artificial tears, there's more that we can integrate it in and more that we can do. And all these are, again, pretty easy for us to integrate in, especially if we need bandage contact lenses. That's something most of us commonly use anyways. There are medicated eye drops like the cyclosporin derivatives, the lifitegrast. There's nasal stimulation with nasal sprays, intranasal stimulation, external nasal stimulation that all stimulates the nerves on the outer side of the lid, outer side of the nose, that ties into the tear gland and help produce healthier, better quality tears. For really severe staining, very symptomatic patients, a lot of inflammation on the eye, I like to pull out amniotic membranes for these patients. We utilize both the dehydrated and cryopreserved in our office too, again, kind of depending on some of the severity here. And then something a little bit more nuanced, but the autologous serum, platelet-rich plasma. I like these for patients that especially want a more natural approach, being that it's their own blood that's used to make these. That's something that I've had pretty good success with on the few patients that I've done those medications on. As I mentioned earlier, I really like to have inflammatory testing in my office as well, because it really helps key me into, am I improving their inflammation? The specific test, Inflammidrive by Quidel, it detects MMP9 inflammatory mediators, quick results, low cost to the patient, low cost to the practice, and it's consistent, very easy to perform. I often have my technicians perform this on my dry eye workups prior to us instilling any drops in the eye. I graded it on a 5-point scale that you can see here out top, that was in a poster with that Dr. Dave Kading and Mile Brujic presented, that basically the more pronounced that red line is, the more inflammation that they have in their tears. And so that can kind of key you in on how aggressive you need to be with their anti-inflammatory treatments. One thing you can really do to be a hero to a lot of your patients, and is often overlooked, is poor eyelid seal, nocturnal log-ophthalmos, specifically correlated with sleep apnea. If you have a patient that has morning symptoms, whether it's they wake up and their eyes are blurry, they wake up and their eyes feel stuck together, or they're watering in the morning. People think I'm crazy. The patients think I'm crazy when I say a lot of times their watering is in response to dryness. But most commonly, if you have a patient that has morning symptoms, they're not sleeping with their eyelids shut at nighttime. On this next page here, what I do to test for this without sneaking up on them at nighttime with my transilluminator, I'll have them gently close their eyelids in the microscope or in the exam chair. I'll rest my transilluminator on their eyebrow just so they don't tense up, and then I'll gently slide it down to their upper eyelid. As you can see in this picture here, that there's light shining through underneath that eyelid, and that is a clear sign that that patient doesn't close their eyes very tightly at nighttime. And so a couple of ways that I like to address this, because if you start out the day poor, it's hard to improve that. So I like to prevent that dryness from occurring right from the get-go. I like to utilize preservative-free ointments before bed, but oftentimes a beauty mask or a sleep mask is enough to just gently seal the eye shut. Especially if the patient has ceiling fans or AC or windows open, it helps block that moving air, but it helps just seal that eye shut too. Oftentimes, I'll tell people if they use the sleep mask but are still symptomatic, add on the ointment. But I've had patients tape their eyes shut. I've had a patient wear big swim goggles to bed to help basically form a greenhouse effect over his eyes. But there are masks that are specifically designed for nighttime wear, such as these two on the bottom here that helps close the eyelid, prevent the eyes from drying out at nighttime too. It's often important that we don't overlook blepharitis. It's such a common finding that sometimes it doesn't register. If it's mild, then it's not severe and inflamed like some of these images show. But we need to make sure we're clearing the eyelids of blepharitis. Several different types: staph blepharitis, seborrheic, which is more oily and greasy as opposed to flaky and crusty. And we're all familiar with our friend the Demodex here. That's an infestation of the eyelids. There's 100% correlation of patients that have collarettes around their eyelashes here, like this picture on the bottom left shows, that have collarettes. And so we need to, or that have Demodex infestation. So it's important that we take care of that and clean the eyelids too. So you can utilize eyelid cleaning foams, tea tree oils, hypochlorous acid. If I have it where a patient has any inflammation or a significant buildup along the eyelids, I always tend to recommend eyelid exfoliation in the office too. And so the eyelid exfoliation in this study, it was a small study here, but one treatment with eyelid exfoliation did improve the OSDI scores in these patients, did improve the TBUT scores in these patients. It helped the inflammation with inflammatory in these patients too. So just clearing that eyelid alone can make a big difference in your patient's comfort. I'd like to share quickly a rough outline of how my protocol is here. So on the left, this is kind of a standard. If I see this, then I do this on my dry eye evaluation. So most of this was modeled after the DEWS-2 study, which again is a very, very long study, very well detailed. So I really encourage you look up the DEWS-2 study and get very comfortable with their treatment protocol. But most of what I have here on that graph on the left, or that chart on the left, is derived from that too. Something I didn't mention that again is pretty easy for us to integrate in. Don't forget about punctal plugs. I know, again, going through punctal plugs on patients that might have inflammation can be potentially problematic, but on patients that need more tears on their eyes, you can do very temporary punctal plugs that let them have more tears while you're managing the inflammation as well. So keep that in there. Something, again, that helps me with patient education, because I'll spew a whole bunch of different things at them over the course of a 15-minute conversation. I have this dry eye treatment plan paper that I'll circle what I'm recommending to them and hand that to them. Otherwise, it goes in one ear, right out the other. Hopefully they'll remember one or two things I mentioned, but if they have this paper when they leave after my dry eye evaluation, it makes managing their dry eye and their understanding a whole lot easier, and they know exactly what I'm recommending for them too. So in summary here, as I went back to the initial limitations on why some doctors don't get into dry eye. Do you follow the signs or the symptoms? My thoughts on this is you improve the signs that you see and the symptoms will follow. Be aggressive with anti-inflammatory treatment. Oftentimes, if we calm the inflammation down, the patient's symptoms get a whole lot better too, while you're also managing the other contributing factors. Because there are so many different treatment options, identifying those major factors that you're seeing on the patient and targeting those specifically. And as you improve on those, move on to the next one and keep improving, keep improving. Equipment can be expensive, and it is a big hurdle, especially those more advanced therapies. But what you have in your office already with the lissamine green, the fluorescein, using your hands or fingers or Q-tip or meibomian gland expressor to get a good base and at least start out your patient care in dry eye. You have the tools available. It's just a matter of jumping in and taking the time to do that. It is time consuming, and the biggest factor on taking care of patients with dry eye is you have to do a lot of hand holding and encouraging, but do what you can to maximize your scheduling efficiency, delegate every task that you can comfortably to your technicians or your team that works your patients up, because then you can spend more time one-on-one if they get all the heavy lifting out of the way. And then ultimately, non-compliance being frustrating is unfortunately a big part of that game. Because again, if you start improvement, the patient feels better. They don't have that constant nagging sensation to continue on with some of their treatment.